webinar on 21st Century Primary Care, subtitle, Engaging Patients in a Digital Age. I'm really excited. We've got a couple of great speakers this afternoon. A little bit of housekeeping first. One is that we are recording this webinar, and so the recording as well as the slides themselves will be posted in our website after the call, probably within a week. To please reduce distractions and background noise, we're asking everyone to send their calls to voicemail, silence your ringers, close your other applications. Because it's looking like we have a fair number of folks on the call, I'm probably going to go ahead and mute the non-speakers. But as long as you've dialed in after you logged into the webinar, I'll be able to unmute you and you can raise your hand to ask questions after the speaker speaks. Please don't put your phone on hold, though, because we will all hear the music, and while pleasant, it's very distracting to others. And to ask a question, I'll put this back up afterwards, you can go ahead and either use your chat function and type the question in the chat box, or you can raise your hand by clicking on the hand icon that you'll see on the right side in that right column where you'll see yourself next to your name. And as long as, again, you phoned in after you logged in, I can unmute you. There are quite a few number of callers who have just called in and are not associated with their names, and I won't be able to allow you to speak because of that. So, our speakers today are Dr. Jason Cunningham. He'll be speaking first. He's the medical director of the West County Health Centers, which is a mid-sized community health center in western Sonoma County. He's been the clinical champion of their EMR implementation, which started in 2008, and also their patient portal, which opened up in 2010, and has been leading the clinical redesign work there towards really trying to become a patient-centered medical home. He has a passion to see primary care provide innovative, effective services in this new healthcare environment and has been a speaker at numerous health forums on this subject. He has his Bachelor of Science from University of Michigan and his medical degree from Kirksville College of Osteopathic Medicine. He will be joined during the question and answer period by their Executive Director, Mary Seze, and she's been the Executive Director at West County Health Center since 1995, has over 30 years of diversified program management and administrative experience in the nonprofit and healthcare sectors in Northern California, as well as the Asia-Pacific region. West County Health Centers provides comprehensive, quality, and accessible healthcare services at 5 locations in western Sonoma County, and Mary is the president of the Redwood Community Healthcare Coalition and also serves on the board of directors of the California Primary Care Association. She received her Bachelor of Science degree with honors from UC Berkeley in 1979. Go Bears. And so our second speaker will be Dr. Thomas Lee, who is the founder and CEO of One Medical Group. Tom is an accomplished entrepreneur and innovator in healthcare services and information technology. He started some noteworthy ventures to date and is recognized as a leading visionary on health information technology and medical practice transformation. At One Medical Group, Tom has helped create one of the more distinctive primary care models in the country, using information technology to dramatically improve the quality and service of care while also lowering administrative costs. Prior to One Medical, Tom served as the Chief Medical Officer, Editor-in-Chief, and Lead Designer, Marketer of mobile applications for Epocrates, which some of you may be familiar with. It's currently in use by millions of healthcare professionals worldwide to reduce medication errors. And footnote, he was briefly a Senior Program Officer as well here at the California Healthcare Foundation. Tom received his BS from Yale University, his MD from the University of Washington, and MBA from Stanford, and he's a board-certified internist with training completed at Harvard's Brigham and Women's Hospital. So I'm actually going to hand the presenter role over to Jason so he can speak. And Jason, why don't you take it from here?
Great. I think we're all set. I'm very honored to be part of this discussion, and
with Mary Seiche, I hope to have a little bit of a balance between administration and clinical. We oftentimes go to these presentations and hear from the executive directors, yeah, that's just lofty and doesn't have a whole lot of grounding financially, and I hope to demonstrate that we really have a really great group that's aligned, and I think she can offer some credibility around that. Also, when I go to these things, it seems most beneficial to have something to come away with, and so what I hope to do is set us up a little bit on who we are and what we're about and where we came from, but be very practical and try to be able to give you some things that you can take and run with it even tomorrow. So to start us off, like we said in the invitation, that we are a mid-sized community health center. We're a federally qualified health center, and we service our patients in the western part of Sonoma County. We have 3 standalone clinics, a dental clinic, a teen clinic, and we just opened and very happy to announce a Forestville Wellness Center that we're doing health education and so forth. But our story really begins a couple years ago, and I put this slide up, and I hope if you heard me before, you're not going to get bored of my jokes, but this is what it felt like about 2.5, 3 years ago when we were asked to start a new community health center in Sebastopol. And at the same time that we did that, we were going to be the lead at our implementation of our regional coalition for electronic health record. And we decided that if we're going to start new and start fresh from a new site, that we didn't want to have any paper in there, and that we would start at that site with our electronic health record. In doing so, we felt like that we should just restart and rethink what we're doing and do a clinical redesign at the same time. And at that time, the medical home concept was just starting to take hold. And we spent a lot of time figuring out who we were and the why. And so I wanted to set us up a little bit on the why and what our principles are, but then go into what I think are the more exciting kind of technical aspects of some of the things that you may want to take from here. So this is what it felt like for us around 2.5, 3 years ago. It felt like we had a huge task in front of us. Record. We thought we were aligned with why we chose it. We chose a good product to do clinical work, but we had a lot of work to do. And at the same time, we said we're going to restart and say everything that we know about community health centers, everything we know about primary care should be rethought, our workflows, our staffing, our ratios, our financing, and we tried to start fresh. And I can say at this point, it feels like we're doing this. It really feels like we've gone past the initial hurdle and are really enjoying the benefit of really taking a long time to do the why. We have gotten benefit from the California Healthcare Foundation, from the Institute for Healthcare Improvement, among others, around the foundations of the why. And I think we are all, in my opinion, at a very exciting time in primary care. And as long as we can step back and say, why are we doing it? I put this slide up here because I think TransferMed really offers us a lot of credibility and foundation in what we're doing. But I worry a little bit in the NCQA and the TransferMed and the concept of the primary care medical home that we're going to move forward so quickly and checking boxes off, and we're not going to do what we really want to do in the end. And I put this up here because I think TransferMed does better than most at really explaining the foundation of why. But in general, this concept of the patient-centered medical home really has a foundation of offering a continuous relationship with a personal physician, and I would say personal clinician. We have really neat nurse practitioners and physician's assistants who are doing really wonderful work, but it really is embedded in that relationship. And that relationship is not just any relationship, but it really allows us to coordinate care for wellness and illness. And if primary care can move towards that direction, we're going to be in a whole different place in our country's healthcare delivery. But we're a long way from that. And we spent a long time at our initial stages of this healthcare redesign in really stepping back and rethinking the principles of why. And I use this slide so many times that I feel bad. I should almost pay Chuck Kylo and Doug Eby for rights to use it. I had a speaking engagement with him a while back and gave him some credit. But I think they've done a good job of really explaining the why in one snapshot, in that primary care really needs to rethink who we are, that we're not a product industry, that we're really a service industry, that in order for us to really do what we're being asked to do, we need to focus on coaching and teaching and partnering, that the concept of decision support and what we need to do for diabetics is really secondary, that it's the primary has to be based in this concept that we're serving our patients. And that primarily changes who we are. It changes who we hire. It changes how we train, how we structure, how we reward. And if we can focus specifically on optimizing that relationship, that personal, trusting, accountable relationship, then we will go a long way towards achieving what we want to have happen. And so what we did initially is set up 6 principles. I'm going to talk about 3 of them today. And our first principle talks about relationship, that we really think that at its core, our product is a relationship, that if we can offer a continuous, trusting, non-judgmental relationship over time, then we've gone a long way to really allow our patients to trust what we're doing, to follow our advice, to really understand who they are. And we would say that that relationship is beyond West County Health Centers. In fact, it's really a first-name relationship. So we have structured our entire teams around the concept that really you get to know 4 to 5 people by a first-name basis, and you should interact with those people, if at all possible, every single time you make interaction with our health center. I love this quote from William Osler. It says, it's much more important to know what sort of patient has a disease than what sort of disease a patient has. And I put that up here because we spent a lot of time really worrying about our implementation of our electronic health records because we really felt like it may undermine the trust of our relationship. If we were sitting focused on the wall or the computer and our back was toward a patient, I feel like we can have all the gadgets in the world and it's going to undermine what we're trying to do. And so here's an example of one implementation that we chose. We chose tablets with a room designed in this way, so it's really enhancing the relationship. I think you'll see Dr. Lee's presentation in the same way. Focusing on the environment really makes a big difference in preserving that relationship. And the technology really is a tool, but is risky if we don't really focus on that relationship. We have spent a lot of time over the last 6 months or so talking about the patient experience, and that the relationship really is foundational with everybody who interacts with that patient is going to enhance or detract from it. We have hired some wonderful providers and, like me, tend to talk and get relational and spend a lot of time with the patient, and unfortunately spend some of their time in the waiting room. In fact, when our patient satisfaction surveys come out, we do a great job, 95% plus oftentimes in most categories, but 75 or 80% on our waiting time. So what we did is we looked at the pager system, that you go to Applebee's and you're having a long wait, they give you a pager and you go wait at the bar and spend money. We felt like that would be a good tool for us to use. And so this is an example of an opportunity that we felt that we could use information technology or technology to enhance the relationship, and our patients love it. So this costs about $1,000. It's through LRS. You can get a number of different products out there. And when our patients are waiting more than 15 minutes, or if they want a pager to begin with, they can wait outside, take their children outside, and wait for us to call them. So there's an example for us of really focusing on that relationship, measuring that relationship, and how we're doing, and then acting on it from an information technology perspective. We feel like texting is going to be the wave of the future. In fact, I heard from a recent presenter that most of the freshmen in college nowadays are not getting emails because they just don't use emails, but they're texting. So this is a picture of one of my patients in the nursery who was born with a pager or with a cell phone and was texting, OMG, I just got born. And we felt like we could use texting as an opportunity for us to communicate in a different way. And so we contacted Message Media. It costs us about $50 to provide 700 text messages, and it goes through our Outlook. So we type into our Outlook, and we're able to text patients. And we're using it very initially. When I'm running late, 15 or 20 minutes late, my medical assistant will text my patients that I'm running late. It's okay for them to come show up a little bit later. So there's an example for us of using technology to enhance the relationship. And it's cheap and it's out there. Our second principle focuses on access to care, this open door concept that all barriers to timely access to this first name relationship should be removed. If you don't have access to that relationship, then you have a relationship with the ER or some other provider. So we are very clear on that there's a lot of factors that go into this, but this is where most of our patients initially felt like they were. It takes a long time to get in. They feel like they're at the end of the queue. And so can we change access points? Do we have to have our patients show up in our office? And I think those in primary care who can really understand this and do different models of care will go a long way towards improving outcomes. And so we did implement our patient portal. It's a product that's put out by our vendor, and we felt like very clearly that that was an opportunity for us to provide access to us outside of the visit. And I'm proud of this slide. We chose to say that that is one tool, but how we use that tool is really up to us. We put a questionnaire in here that allows patients to enter in items that they want to discuss at our next visit. So it's their agenda piece of paper they show up with. They're able to enter that into the portal, and it dumps right into our notes. So a good example of using a tool for enhancing relationship in the way that you are able to move forward with. So this is another slide I'd like to focus on. We'll touch on it just a little bit at the end, that we feel like technology around video conferencing is also something that is no longer a barrier to purchasing a very expensive high-tech device. It is out there now, and so no longer do we have to wait for grant funding to get some specialized technology. We can just tap into an existing and growing technology that our patients already have access to. So this concept of using FaceTime or Skype or iChat to be able to interface with our patients, I believe very strongly that we need to tap into this. So can we, as federally qualified health centers or private practitioners, interact with the patient even more successfully than on the phone by using a chat? So we are talking with Cisco at this point about using some of their technology around WebEx, and for mobile technology to have our nurses go out to a homeless population, to the home visit, and video conference back into us. And we feel like that we can even bill for that, so we're looking at that legally. How can we provide care financially successfully using video technology? And there's all sorts of opportunities for you to use that in a different way. But no longer do we have to wait for some new technology to develop. It is already out there. We just need to tap into it. Our third principle is around team-based care. In my opinion, if you don't have a sophisticated care team, there's no way that we're going to provide care in the way that we really need to in primary care. So our principle is that excellent care can be offered only when you have integrated care teams working at the top of their license. And we've spent a long time trying to get away from this and move into having a developed care team. And we've done that, and we've spent about a year and a half developing very distinct workflows, and we're really realizing the benefit of that at this point. I put this slide up there because we have to recognize that you not only have to say you're a care team, but you have to really recognize that each care team member has a different role, and then you have to spend time really isolating those roles, training it, and making sure you're managing that as well. And I put this up here to say that what the chronic care model really focused on was developing kind of informed, activated patients, but it's on the foundation that you have community resources and community partners that you're engaging with, and I think this is one of these last frontiers that we really have not done very well. And I think there's real opportunity for using technology to really engage with community partners. And so this last slide here it's kind of busy, but we've put a couple of these technology pieces that we're working on in an opportunity to really say, how do we interact better as a team, and how do we interact better with the community? And so as we've developed these kind of comprehensive care teams, we recognize that communicating even within our office is difficult, much less across our 3 sites, and even worse across the community. And so we are also talking with Cisco around the WebEx technology for us to be able to have video conferencing at all of our sites, and so that we can interact with each other for care conferencing and care coordination visits in a way that's far enhanced than what we do now. It's hard for our nurses to really walk down the hall to have a really integrated visit with a patient and a provider at the same time. We feel like we can do that in a much better way using the WebEx or some of these technologies. We feel like the instant messaging is another opportunity that we have. There's a real problem with making that secure, and I put Brosix up there. Brosix and Big Ant are good technologies to look into that are fairly cost-effective, and they're secure, and so we can use instant messaging within our office so that when I'm communicating with my medical assistant, when I'm in the room, I can I can instant message them what I need. When my front office person gets an instant message from my back office saying, please text my patient, we're running behind. They don't have to run up and down the hall to do that. And then the concept of social media is another opportunity that we have. I feel like we can move into having our patients be active participants if we give them more of a voice with each other. Our group visits are very successful because they tell each other things that I can't tell them. And so we're speaking with a company called Yohala, which is a very secure social networking site similar to Facebook, much more secure. And we are very excited about that possibility to be able to offer secure social media, social networking with our patients. So the last frontier for us is to be able to connect our community partners with cameras, to be able to do warm handoffs, to be able to have them sign up for stuff for in our office. If a patient shows up in our office, we can connect them remotely or through video technology to other community partners in the community. We feel like that's a real opportunity for us to move forward. So I put all these different opportunities that we're starting to engage in as a hope that it would start to be a little bit provocative for this discussion, and we certainly would be interested in taking further questions after the call.
Thank
I'll
you.
turn it over to Dr. Lee.
Yeah, so I'm going to unmute you, Tom, and I'm going to take back over the presenter so I can drive his slides. So, Dr. Lee.
Great. Thanks for having me. It's great to talk to a great group of providers and institutions that are working on good stuff. So I appreciate taking the time. I'm going to talk a little bit about my background. I guess if you asked, maybe I could give a little bit of context about where I've come from, and then maybe talk a little bit about what we're up to at One Medical Group, and then certainly we can discuss, a lot of different dimensions of how technology can enhance or detract from the patient experience. But fundamentally, we're a service organization using technology, not the other way around. If we go maybe the next couple of slides, Sophia. So really, kind of my background is originally trained as an internist. The values that I grew up with, you can go to the next slide, Sophia, was really looking at how can I kind of bring back the old school model of primary care back to healthcare. So when I was originally envisioning how I would practice medicine, it was more akin to the house call doctor who would come and visit their patients at home. And that was my vision of what healthcare should be. At the University of Washington, I had great exposure to a variety of healthcare settings, and as well in Boston. And it became pretty clear as I was going through my medical training process that the people were all good. They all had the right ideals. They wanted to do the right thing. The system just wasn't supporting it. And, we obviously, have our theories and know why the healthcare system is the way it is. But a big part of it was just the financing and delivery systems were not necessarily reinforcing and, in fact, detracting and deterring often from the patient experience. So, I'd always geared myself towards being an academic clinician, but, as I kept running and getting closer to the practice of medicine, it became clear that I wouldn't be able to practice the way I wanted. So I did some schooling. I, came out west, got some business training, and then really kind of had to get deep into the technology. I wasn't a technology guy. And decided to kind of really invest more deeply. So worked with a couple friends on starting up Hippocrates, which is a mobile technology company focused on providing clinicians with data at the point of care to better support their decision making, and certainly got a better understanding of the power of data and how software can enable, facilitate, and allow providers to be better clinicians. And so, having had that experience, I felt comfortable starting up One Medical Group. Maybe you can go a couple slides forward, Sophia. Just the concept of One Medical Group is pretty much, it's a very basic principle, but I wanted to start clean slate, build kind of a medical group concept that's really focused around the patient primarily, by building the administrative support systems to support the provider and using the technology infrastructure to better support the process. And so while that sounds kind of simple, there are a lot of details necessary to kind of get that to work. And a big principle that we had was that as busy as the primary care office was, it was probably just being run a little bit inefficiently. I mean, there were a lot of people doing a lot of work, but maybe that work could be redesigned. So we took a fresh look at the administrative processes of supporting physicians in practice and providers in practice, and re-engineered kind of how we thought care should be designed around the patient, and built technology kind of off the shelf and in-house to support it. And so, since then we've grown fairly rapidly in San Francisco, and what we wanted was a model that could also scale. There are a lot of fantastic groups out there and models out there and individual providers out there, but how do you get a system that can actually grow and scale and be repeatable? And so that's been kind of a core focus of ours. So one, can you find a business model that supports kind of a better primary care experience, but then two, can you create a scalable model that allows us to kind of replicate this? And so far we have. We've opened up in New York, and we'll likely open up in other markets as we continue to grow. If you go to the next few slides, just they're really just kind of the offering of what we. What patients experience is what you'd expect from a modern healthcare service today. Same-day appointments, longer visits that actually start on time. Email and phone access to your provider, online tools and mobile tools, and we work within the insurance system. We think that the insurance model has its flaws, yes, but it's how most people are used to working with their healthcare, and we believe that working within the system is more conducive. But anyway, so the experience as kind of patients feel it is a warmer place, a place that's kind of designed more thoughtfully with staff that are trained in kind of much more hospitality type of orientation. In the next slide, you got to get a sense of kind of the office space. We were recently featured, but that gives you kind of a sense of the space. And the reality is, it's rare that people are sitting in our lobbies because we do same-day booking or we start our visits on time. So the lobbies give people a sense of space and place, but it doesn't necessarily mean they're sitting there very long. In the next slide, you can get a sense of the warmer kind of interior space. We have kind of these cloth robes that kind of are much more kind of conducive to creating a much more friendly environment and inviting environment. In the next slide, you can get a sense of some of our technology. So a lot of our web-based infrastructure is designed and built in-house. I obviously have a software background, so that is more feasible with our type of a model. But patients register online. They can certainly enter their health data online. The physicians and providers are all supported with basic web-based EMR and electronic prescribing systems. But then we also extended the experience. So similar to what Jason's talking about, there's just fantastic technology out there that helps you extend the experience and the relationship beyond the office, and that's a big part of what we're trying to do. And we don't chase the dollars that come into the office per se. Yes, there's certainly an amount of visit revenue that you need to kind of support the practice, but we also invest in digital experiences that aren't reimbursed, and we accept that as given. But it's a better patient experience, and it's better quality and access for patients. So one of our mobile phone devices, patients can triage themselves if they need to come in for, let's say, a UTI that's simple. They can also book online and interact with our providers in a virtual fashion. On the next page, we're also interested in educating our patients. So we have a content blog that captures some of the kind of lifestyle issues that we want to encourage patients to consume and kind of be aware of. So it has our philosophy, our style of care, and it's a nice way for our patient base to interact with us in a more kind of at-leisure environment. And then I think that's pretty much it. Wanted to leave time for questions and otherwise.
Thank you. So I'm going to actually unmute all of our presenters. One of the first questions that came through, Tom, was a question about whether or not you currently accept fee-for-service Medicare.
We do. Our intent is to provide as accessible care as we can for as broad of a population as we can.
Great. And so one of the other questions I think to both of you is, what do you guys think is the prospects for providers being reimbursed by public payers and private insurance for video conference and other remote care, such as social media and texting and using those modes? You want to start, Tom?
Are you asking about telemedicine?
Yeah,
or
just
video?
About being reimbursed for telemedicine and kind of interactions via texting and other remote.
Sure. Yeah, the key constraint is primarily the financing model and how that financing is captured by the organization. So I know some of the organizations on the call are more paid on a global basis, and those groups can probably more creatively find ways to care for populations. For those that are more, focused on fee-for-service, it's a harder model, right? So I think there is some reality to trying to figure out how to pay for those services, assuming those are desired services by our patients and are cost-effective and reasonably clinically reliable. So for the right situations, I think those are doable. But even organizations like ourselves, that we've got some degrees of freedom, even though we're in a fee-for-service environment at this stage. There are ways of creatively doing that. Just it's very use case specific. So unless there's fundamental payment reform or how the dollars are being allocated at risk, I think it's challenging. But I'm sure Jason has probably a lot more thoughts on that.
Jason?
I agree. I think what I heard Dr. Lee talking about that I really agree with is you got to kind of figure out who you are and do it because it's the right thing to do. And so for the texting and for the emails and even for potentially video conferencing, there's a lot of value there that you really need to just do. And I think if you're creative in your environment and you understand your environment, and I'll let Mary talk about this a little bit, but we spent a lot of time really understanding who we are in that financial environment and working the system so that it meets the needs of what we're trying to accomplish. And I think if primary care doesn't do care coordination and case conferencing, if we don't bring in family members, if we don't talk to community resources, if we don't provide better access to our patients, we're not going to be doing what really we're asked to do in primary care, which is care coordination and case management and all the other stuff that we really don't do in primary care. So I think in our mind, it's the right thing to do. It's the right thing to have web access. It's the right thing to text patients. It's the right thing to have video conferencing. It's the right thing to start enhancing this care team beyond the medical model into the community model. And you really can't do that without technology. So it's a little bit of not answering your questions fully, but to say we've got to start playing in that, and we won't know what the opportunities are until we're playing in that environment. So to a certain extent, you just got to play with a little bit of financial risk in making it happen. And then, and I'm sure Mary would add to this, that you really have to understand what financial opportunities you can leverage in your current environment. So I don't know, Mary, if you want to add to that.
I think you said it very well, Jason. And the only, obviously we have a lot of different payers. Some of them we get paid capitated payments, and we definitely are working those systems to try to get as much, covered of these types of different modes of communicating with our patients out of the payment that we receive. But I think what Jason said is right, is that we're interested in demonstrating how these things work. And I think we actually have found that there's some internal value as well in terms of, creating efficiencies for us in, not having the patient call back 1,000 times to get something handled, that if we had better care coordination with, other parts of the system, that we'd be able to manage. So I think we've seen benefits just in terms of our own internal efficiency as well, that, we didn't exactly know because we hadn't tried some of these things. So payment reform, of course, is the holy grail, but we don't know when that's going to happen.
And I guess on the payment question, Tom, someone was asking whether or not you have a retainer fee for your service.
Yeah, so we kind of shy from the terms concierge or retainer. That's how people describe a high-touch practice, and we get lumped into that, but we really don't view ourselves as such. Certainly we ask that our patients support our practice style with a nominal fee. It's, like $150, $200 a year. But it's not a requirement for care. So it's more like a contribution that our patients decide to do. And it helps support our model in terms of investing in services that aren't really paid for by payers. So, online consultations and a lot of these kind of virtual consultations, obviously, are supported by that. And to that extent, doing more, teleconferencing and video conferencing is helpful. But there's a separate aspect to that just kind of dimension, which is it's a little bit more difficult to coordinate because of the scheduling, issues. So it depends on how you want to do that specifically. But for us, that hopefully describes the model.
Great. I'm going to collapse two questions here. I think this is mostly to Jason and Mary, which is How do you get feedback from patients and staff about how they're responding to the new technologies and approaches? And how do you identify opportunities to tweak and improve? And then someone else asked, have you had any real surprises in that process?
I think that's a really good question, and I think it goes to organization structure and non-kind of IT stuff. It's just how you run your organization. But I think they're really valid questions that when you're just doing something and you think you're doing the right thing, you don't really know until you're at the other end of it and you're asking the right questions. And I think there's a lot of good work that's going into that right now. So we spend a lot of time doing surveys. We spend a lot of time doing staff analysis, and our organization structure is set up where we have different leadership meetings on different levels that we can get input from. We are working on patient advisory groups. I think there's a lot more work that we could be doing around kind of the secret shopper and the patient stories, and a lot of what's being done around the patient experience. I can tell you that one of our examples around our portal, we spent almost 7 months working with 5 patients, really spending time from the patient's perspective, making sure we were doing it right. We spent very little time kind of rolling out the why and how beneficial it would be for our staff. And finally, when we were ready to roll it out, we got so much flack from our staff about all the work that was going to be piled on their desk that we put it on hold for another 3 months. And so it just goes to the concept that you really need to spend the time getting the right feedback and really focusing on the why, convincing, marketing. When we opened up our open access concept, we really had to have the providers really knowledgeable about the why so they could convince the patients that this is a new way of scheduling. You got to spend a lot of time doing the patient and staff education. And we do still have surprises for sure. So the answer is yes, we do.
Do you have an example of a surprise?
So I think the example that I just gave around the patient portal, we thought that it was going to be a hard thing to sell to patients and a kind of a hard thing to sell to providers, but a no-brainer for the front office because a lot of that work was going to be taken off their plate. And in fact, it took us a lot more time convincing our support staff that it was going to be a good idea than we thought. And so you just kind of have to walk forward and recognize that you're going to have to be flexible in your timing of implementation and really focus back to say, did we do that right? Should we do it differently? So patients love it. Providers are loving it. So
on the question that you got, what problems did you encounter with patient acceptance? I think, Jason, we had less problems with the patients than we anticipated. Our patients have been very accepting. In fact, they're probably pushing it more than anybody. And so that was a surprise that that patients really want it.
Yeah. Yeah, we spent, literally a year doing patients focus groups, and then it wasn't a problem with the patients; it was more the staff. So
one of the questions.
Yeah, the only thing I would add. Oh,
sorry, go ahead, Tom.
Oh yeah, I was just going to add. The key issue with thinking about absorbing technology into your practice is. Unless you make it the only channel, it's one of multiple options, right? They can still call, they can still do other things that are traditional. So it's just another option for people. That's a good thing in the sense that it gives people choice. It's a bad thing internally, operationally, because it just means you have to manage different workflows. So the key to being thoughtful about the technology integration is being aware of the different types of workflows and therefore the different workflow incongruencies. And I think a lot of practices tend to focus on linear workflows, and that's simple because everything goes into one bucket. But I think as you add technology, it potentially could add to 2 buckets or 3 buckets, and you just have to be cautious of that.
Yeah. And in addition to that, if you focus on the why, it's a much easier sell to your staff when you're using your technology because it's adding to this underlying culture you've developed. And I know that you've done that a lot, seeing what your slides are, Tom, but if there's something about really getting patients on board of what we're doing, it's much easier to then implement technology around that.
I have a follow-up question maybe to both of you, both sites, which is, how do you align the patient's expectations for your availability? Or do you have a number of patients who want a lot of time and energy? And if so, how do you deal with that? Their concern is that there's a lot of fear in thinking about implementing a high-touch practice. Tom, you want to take a first cut at that one?
Sure. Certainly that is kind of a big concern. As you reduce the natural barriers to kind of access, there is a concern about being overwhelmed. There's a couple issues there. Is if you lower the access to your staff or otherwise, you will get a higher volume. So that's not a fallacy that there's a truth to that. And you need to be prepared to better handle that. But that's demand that is queued up somewhere else. It's right. People who've decided to not really join your practice or really like your practice, or it's stuff that's stacking up behind the phones anyway. So it's just another release valve that you're going to need to do that work anyway. It's just going to come faster and sooner. So there is a reality to that. There's a second issue, which is most people naturally have the right expectations for the right channel, right? So people don't expect 1-minute turnarounds via email or 1-hour turnarounds via email. Some do, but most people are realistic about which channel they choose for the time expectation. And when we end up with incongruencies, it's important to re-educate patients on that because they're learning a new medium. So we do put warnings on our out-of-office replies that say, email is a non-urgent form of communication, expect a response in a business day, that type of thing. And it's creating that right environment of expectations that you sometimes have to reinforce because some people don't get those implicit contracts clear. But most people are pretty good about it, and for the ones that, kind of fall off the edges, you have to kind of nudge them appropriately, just like there are people who come into the office inappropriately. Anyway.
Mm-hmm. I would answer that in two ways. I would say that we have a system that we've had for decades that has patients coming in for a volume-based service where you're being seen by a medical provider, usually a physician, and that is going to need to continue. We need to continue to do that. I would say that we can do it differently, and in fact, going back to the initial point, you need to manage the supply and demand around that, and we do a lot of work around panel sizes and giving relative panel sizes to age and disease acuity, and you need to manage that supply and demand, and you're going to have to continue to do that regardless of your kind of product. But I would say that we need to move quickly into another model of care and say that the team-based care and concept that maybe it isn't the clinician or the provider that needs to be seeing a patient, but there's going to be an extension of that trust that's developed to a nurse or a navigator or a coach or some of these other kind of support staff or community service that really do that better than we do, and that we can change our capacity because we're changing the way that we practice. And that's where I think we really need to step into, because I think if we're not providing this high-touch care, then we're not doing what primary care needs us to do. We need to be able to develop that trust over time and be able to know our patients. And so for whatever reason, one way or another, we need to move in that direction.
Another question, and I don't know, I'm trying to remember, Jason, if you had some data on this, but someone asked about the penetration of cell phone use in low-income U.S. populations. I know we at the Foundation actually do have a report on this, but I don't have the numbers at the top of my head. It's actually quite significant. And the concern is will low-income populations be excluded from this type of care?
So we do have some numbers, but our N is not large enough to kind of make that translatable outside our system. But the cell phone usage is very, very prevalent, even in our underserved and Hispanic population. Whether or not they then have access to a web, whether or not the web technology is bilingual or bicultural is a whole other question. So I think texting and cell phone usage, everybody's got it now. But to use that technology in a different way, I think is a bigger question.
And Tom,
I would just add that what Tom said earlier is true, is this is just one avenue for people to access your services. So it's not the only thing.
Yeah.
And Tom, have you had, what's been your experience with the kind of cell phone use, in particular the cell phone apps in your practices so far?
Yeah, our bias has been to not open that channel up, so we don't have text or chat as a common channel for our patients. We prefer email, and certainly there's iPhone apps and kind of mobile apps that we've designed, but they're more user-generated, meaning the user will kind of use those on their own and they'll interface into our system. So we haven't used a lot of chat. We think text is a great reminder system. So, as Jason alluded to, some of these SMS reminder type of systems I think are fantastic, but we haven't used it as another channel of communication because then it becomes a little overwhelming. So we try to narrow our channel to email and office visits at this time.
Great. It looks like Jocelyn, did you have a question? I just unmuted you. Are you on the line?
Yeah, can you hear me?
Yes.
So my question was, in the patient portal slide, there are options of up to 5 items to talk about with your provider. And if you have a finite appointment slot, don't you find that patients are either looking for things to talk about or perhaps the appointments will tend to run long because they're looking for 5 things to talk about with the provider?
In Genesis, not an issue. They bring in their list, whether I give them a 5 slots or they develop their own list, and oftentimes it allows them to focus better if you give them that opportunity to focus their thoughts. So we haven't had that a problem at all, even before we use this technology. And just asking for it ahead of time allows the patient to drive the agenda rather than a provider driving the agenda, and I think we just have to walk in that a little bit.
And the other thing that, Jocelyn, that I would say is, we with our patient advisory group, we found talking with our patients about this that our patients are very, very sensitive about their provider's time. They do want to use that time wisely, and they understand that. Don't you think, Jason?
Yeah, I agree. Absolutely.
Yes. When we talk with them, and they said, yeah, we don't want. Is this going to be a burden for our provider? They were worried about that.
Yeah.
So
how long are your appointment slots? Typically?
20 minutes.
Yeah,
Okay.
20 minutes.
Thank you.
And I am not seeing a lot of other questions. I've got someone who raised their hand but can't be unmuted. And you guys have questions for each other? We have a couple minutes.
Yeah.
I would be interested in, Tom, in your discussion around the video conferencing.
Yeah, we're a big fan of it, particularly for rural networks. The challenge there is the synchronous environment makes it more challenging. So as much as you can do a store forward or kind of asynchronous, that's our bias for those virtual conversations. But if you can find a good reimbursement system or way to justify it just because of it's the right thing to do, I think those are great systems. But the great thing about kind of looking at technology as a healthcare provider today is as you guys have kind of noted, there's just a lot of off-the-shelf technologies that you can plug and play into your systems these days. And so those technologies are getting better, less expensive. And part of, really a good thing to be doing is playing around with it. It's not deploying it fully in your systems because you're not prepared for it. Playing around with it alone will just give you a better sense of how these things could potentially be used.
Yeah. That's great. And
are you guys doing video or?
We are just starting. Actually, the biggest impetus for doing it is really we have a really sophisticated now, and we're very happy with our nursing staff and our medical assistants are doing population management, and it really is the concept of primary care doing care coordination and case management. Yeah. So we're very interested in that. How do we talk to each other? But then if you extend that beyond and say, how do we talk to community resources and other things, just the physical locale and the difficulties with coordinating that, we could basically get everybody together. So that's why we're really interested in it.
Yeah, that's fantastic.
Yeah, the patients are already using it, so why not have that be another opportunity is something I think we're very interested in doing. So.
Yeah.
So we've got a couple other questions. One is, how large are the patient populations that each of you are caring for in your practices?
Good question. $1 million question.
So, Jason, you want to start?
Sure. So we have, now we're talking about full-time equivalent providers, right? So we have to try to do apples to apples. And for our full-time equivalent providers, we expect them to see roughly 1,000 patients. That is based on a weighted number. So 800 patients may equal 1,000 patients if you risk adjust it or you change it based on age. And so we have Mark Murray has done a lot of good work around panel sizes, and we use some of their adjustments for our panel sizes. So roughly about 1,000.
Tom?
Total
Was that the
number
question? I just want to make sure I understood. It was the panel sizes per provider, is that it?
It was, well, how large are the patient populations of each of the practices? So
okay, got it.
Like
Yeah, I think it'll vary by the number of providers, but roughly our goal is to see as many care for as large of a population as a traditional provider team might. So we're on the order of about maybe 1,500 per provider, something like that.
And we have about 13, I think, Mary, you can correct me, about 13,000 unduplicated lives.
Right.
And how many lives do you have, Tom, right now?
We're in the tens of thousands.
And maybe one or two last questions. One is, Jason, have you seen any increase in patient adherence to treatment plans with your approach so far?
I'm sorry, increase what?
Patient adherence to treatment plans.
Yeah, I think it depends on what we're asking for around the technology, but we're using electronic health records very clearly now to do population health, and so our numbers, and we're trending that. So over the last 6 months, our numbers have improved dramatically around getting care items done, your hemoglobin A1Cs and your labs done, and your foot items, your depression screening and your mammograms and PAPs. I think that's one aspect of it. So we're reminding patients, we're engaging with them around the why. I think a bigger question that's harder to tease out is, do they own their care more? Are they more trusting in the system? Are they more likely to follow up? And we aren't in control, whether we like it or not. We're not in control when our patients leave, and we can tell them to do something, and their grandma can say something else. So I'm not sure if we can tease that out at this point for more soft data.
Right. And one last question then, which is, do either of you have any experience with using automated input devices to relay, for example, vital signs, home blood sugars, or other home measurements that can be electronically communicated from the patient at home to the primary care practice? And is this practical? Does that make sense, the question?
Yeah.
I don't know, Tom, if you have any items. We don't, and we want to. We use our portal, so they'll plug in by themselves their blood pressure readings, but it's not sophisticated in what a lot of people are really doing with the home monitoring.
We'd love to do that.
Yeah, I agree.
Yeah.
So
Yeah,
Tom,
and we don't do that currently. We're not as enamored by it. It kind of falls into the gee whiz category for us, but it'd be great. But there's other kind of higher yield technologies that we'd rather do first.
What are they?
It's more about data presentation and management, frankly. It's about getting better engagement of our patients in their health parameters, and less about capturing every single data element that might exist out there, either at home or in the lab. But it's more about how that data is used. Yeah.
Mm-hmm. And actually, I think that's a really important, broader point, that you can have all the data you want in any sense, but unless you use it and manage it in a way that improves care or improves efficiency, then it's kind of just extra noise. I think it's a good point.
Wow. Well, we have succeeded, number one, and I think having a very engaged audience, and I think we've answered everyone's questions, which is pretty amazing. So I want to thank Mary, Jason, and Tom for a phenomenal presentation today, and to thank everyone who has listened in. And as I'd mentioned earlier, we will be posting both the recording and the slides on our website within the week. And thank you.
Thank you.
Thank you.
All right, thanks, everybody.
Bye-bye.
Bye.
Bye.